Hello, Dr. Andrew Whittamore. What do you think about a consideration of using spirometers in community pharmacies for patients to carry out checkups? Will it improve the patient's outcome, in your opinion?
I think certainly from our experience here, we're seeing a couple of things. One is there is the potential use of microspirometry to screen for patients who might have COPD or asthma, and that's something that locally we've been seeing a lot of to try and increase the pickup of people who've got COPD, because a lot of people don't feel ill enough at that point to come to the doctor, but they're smokers and clearly at risk of having COPD, and they go to the pharmacist with regular exacerbations or with chest symptoms, or because they want to stop smoking. And actually using microspirometry is a good way of highlighting the patient's risk for COPD, whether they've got COPD, and also can give the patient a lung age which can push them into stopping smoking. So it's quite useful for the pharmacist to actually get people engaged in smoke cessation as well. In terms of looking at regular monitoring of COPD, then I think in future there probably will be a role for more monitoring by pharmacists, and in that case, actually measuring lung function on a reasonably regular basis, according to the current guidelines, would be a useful thing to have there. In terms of regular monitoring, knowing the FEV1 is part of what we're meant to be doing. Monitoring patient symptoms is just as important as well, and I think the two need to go hand in hand. At the moment, patients seem to have to go to lots of different places for their care, so if we can reduce the number of visits to the health service in general, then that would be obviously a good thing for the patients. So no, spirometry readings are very individual for patients based on age, their height and their ethnicity as well, and all spirometers would ask you to put in details on that beforehand, and then we'll calibrate the results according to that. There are various charts you can use as well, but most machines now automatically do that for you. Okay, FVC is the forced vital capacity, and what that basically means is the total volume of air that the patient can hold in their lungs. If that's reduced, that shows that actually in total the patient hasn't got as good a lung volume as you'd expect for somebody their age and height and ethnicity.
Okay, Hala, so you're going to do a lung function test. What I'd like you to do first of all is take a big breath in, make a good seal around the mouthpiece and breathe out as steadily but for as long as possible till you can't go anymore. Well done.
FEV1 is what we really look for when we're looking at patients with COPD and with asthma as well. And actually when they've got a reduced FEV1, which is the forced expiratory volume in 1 second, it's telling us that there is a narrowing of the tube, so they can't get as much air out quickly as somebody who's healthy in the same demographic as them.
Okay, Hala, this time what I need you to do is to do a forced breath out. So I still want you to take a full breath in as hard as you can, and puff out as quickly as you can. And keep going, 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 till nothing else is coming out. Well done.
For a patient to be diagnosed with COPD, they must have two things on their spirometry. One is a reduced FEV1 as a percentage of what they're expected to do for their age and height and ethnicity, and the other is a reduction in their FEV1 over FVC ratio. We're looking for an FEV1 of less than 80% and an FEV1 over FVC ratio of less than 0.7. But more important than those readings is actually the patient's history, and people with COPD generally are over the age of 40. They've generally got more than 20 pack years of smoking, and they've usually got recurrent symptoms of breathlessness, wheeze, productive cough, and exacerbations or chest infections. One important thing from differentiating people with COPD from asthma is actually people with asthma have variable symptoms. They're generally less likely to be being a smoker, and actually they've generally got history of atopy or family history in the background as well. So I think it's always useful to get a good family history on that, and good history on symptoms as well. And also the response to medication. People with asthma tend to respond very well to medication, whereas with COPD there is quite a lot of underlying damage that you can't necessarily treat. So with original spirometry in asthma and COPD, both patients will have the same sort of results. But after bronchodilation, then you'll actually see an increase in FEV1 for people with asthma because they've got a reversible condition. And it's certainly worth having a look at the guidelines for performing quality assurance spirometry. So the preparation the patient must have, how to do it properly, and how to interpret the results. And the Primary Care Respiratory Society network have got some great sort of leaflets which are really easy to follow and can actually give you some good support on actually interpreting results. So we saw Hala earlier using the spirometry, which is a quality assured way, and if you've had the right training and right interpretation, it gives very good reliable results. Sometimes we just want a quick test to actually either monitor the patient or to actually screen them for COPD, and some people are using this sort of machine at the moment, which isn't as accurate, it's not as reproducible or reliable, but it does give a result that accurately excludes COPD. So if they've got a normal FEV1 and FEV6 ratio, and they use FEV6 as a surrogate for forced vital capacity, and it gives you a good way of actually excluding COPD or saying whether somebody's at risk. And actually they actually give lung age as well, which is a useful way of getting people into smoking cessation.
It's really interesting to see how spirometers are used. I think pharmacists could be trained to be using them properly. Handheld spirometries is something we can do for screening lung and help our smokers make lifelong changes.
I mean, it's been a really interesting week having you sitting and doing asthma clinics, watching a COPD clinic, and sitting with our diabetes clinics. I certainly know our nurses and patients have enjoyed having you around, and you've been added some very valuable insights into the care for our patients.
And as well, I thank you all very much, and the staff and everyone was brilliant, and I really had learned a lot in that week. And I wish I can extend my stay longer, because the more I stay, the more I'm learning stuff. And thank you very much for all of you, and it was a real pleasure to be in Crookhorn surgery.
Hopefully we'll see you again.